First of all, I'd like to thank the organizers for allowing me to share with them this interesting case. This is a case of a 7-year-old girl, type 1 diabetes with poor control, presented to our ER with redness in both eyes and hearing problem for the last 1 month. Similar attacks happened before, 2016 in both eyes when she presented, normal intraocular pressure. She presented with 2+ AC cells, and you can see in the CT photo she had posterior synechiae as well as glomerulus KBs in both eyes. The fundus examination showed diffuse pigmentary changes with chorioretinal scars that were evident in both eyes. So my first question to the panelists, given this history and the clinical fundus photo, what would be your differential diagnosis?
Well, I would investigate her for all the usual causes of pediatric uveitis. I mean, she does have insulin-dependent diabetes. That may be not linked, so autoimmune causes, rheumatological causes, and infective causes all would be on the differential diagnosis, I think.
I would do the same in a whole lot of investigations to exclude a cause. I don't know what the cause is looking straight off at this, but that's what I would do.
So,
I think looking at the pigmentation, look as if the patient had also a previous episode of some kind of similar episode. By looking at the picture, of course, it looks pretty clear. So again, I would agree with my other two colleagues.
Okay, perfect. So the clinical fundus photo gives us a clue that it might be a sunset glow fundus, which is typical of VKH. So the challenges that we had in our child is the severe inflammation, which would be difficult to control. Type 1 diabetes with poor compliance, that would challenge our treatment options. To top it all off, the patient had a positive BBD skin test. So in general, I'd like to talk about the challenges that we might face in pediatric VKH. They usually present late, like any other uveitic entities in children, and they account for about 12% of VKH cases and associated with other autoimmune diseases, type 1 diabetes in this case. The chronic recurrent VKH is difficult to control, and inflammation is more severe and carries poor visual outcome if complications occur. So to tackle and manage the patient, we tackled each challenge on its own. For the type 1 diabetes and poor control, we referred the child to pediatric, and we did blood sugar control. The positive BBD scan test, we started the patient on prophylactic INH before starting the patient on immunosuppressive agent. And for the severe inflammation, we started her on topical steroids, cycloplegic agent, systemic steroids, and methotrexate weekly. And she was quiet for a while, and after tapering the steroid, unfortunately, she had a recurrence and with poor blood sugar control. So this is another challenge, which is a case that is refractory to treatment. Any suggestions in this case in managing this condition?
Well, I think compliance with the medication, and of course, looking at other diagnoses which have probably which were not included.
I don't have much experience of this, but I wonder if there is scope for increasing her immunosuppression, perhaps.
You used topical steroids, is it?
Sorry?
Did you use systemic steroids?
That is correct, and then we tapered it because she had poor blood sugar control.
Well, then I think you'd move on to intravitreal steroids as the next move.
Okay, she had bilateral disease. So in this case, what we did is that there was a study published in immunology and microbiology that talked about the levels of B-cell chemoattracting agent, that is CXCL13, that was higher in patients with VKH. That led to the idea that the patient might benefit from rituximab systemic therapy. So rituximab is an antibody against CD20 leading to depletion of B lymphocytes. Several clinical trials have demonstrated the effectiveness of rituximab in treating autoimmune diseases. One case reported in the treatment of refractory pediatric VKH, our patient responded well and is controlled on rituximab. So on the lower left photo, you can see this is the only case report that was published on rituximab use in pediatric VKH. And on the right side, 3 papers published on adult VKH. On the upper left, you can see that the article talking about pediatric VKH in general, if you are interested. Thank you so much.
Thank
what
you
was
very
the outcome, having treated the patient with
Yes, so the child received 3 doses of rituximab, one at 0, the other one 2 weeks later. Then the patient received at 6 months, and she's quiet for a while. Although, as you see, this is a chronic recurrent pattern with pigmentary changes. We would expect complications to occur, but we are keeping her under close monitoring, especially with pediatrics with type 1 diabetes.